neonatologist peds cardiology is a very sub specialist.
Mm-hmm.
How many of those are there in this world?
It's mostly cardiologists who are especially interested in neonatal hearts. There's not a true neonatal heart specialty, but within every specialty there are people who are interested in something within it, and
sure. They're hyper focused on it.
Mm-hmm.
Yeah. But you're like your tet babies, right? I mean, they get followed by peds cards for a very long time.
Sure.
Life.
Yeah. Sometimes I've seen adults like dip their toes, like adult cardiologists slowly take them when they're reach like 40s, right? But for the most part, like, and we talk
40s. Wow.
I remember having a 40-year-old patient on the floor when I was a peds resident who was a congenital heart, who was still being taken care of by congenital by pediatric cardiology.
Well, I mean, if they grew with it, then why wouldn't they? It's just continue to see that specialist.
And congenital heart disease is something that certainly pediatric cardiologists see quite a bit of, but the number of people in the world who have congenital heart lesions is very small compared to the number of people who need cardiologists in adulthood. And so it makes more sense in the long term for the people who see more of this to take care of these patients over their lifetime, as opposed to transition them to adult care where they've seen much less of it.
No, it makes sense now that you say it. I just never thought of that, It's like,
because these are inbuilt errors of the heart as opposed to from exposure, right? Years of being mean to your heart, or maybe just having bad genetics, but still not inborn errors of this is broken from the start.
Yep.
But it's just like when you're a pediatric cardiologist, you think a lot about congenital heart disease. I'm a neonatologist, and from my point of view, you would think all babies are born sick or all babies are sick. But really, the vast majority of babies are born healthy and never see someone like me.
Never see you.
Yeah. And you're probably getting quite a bit of the payload from the area, too, since there aren't many specialists, right? I mean,
the Cleveland area is actually fairly saturated.
I meant Cleveland in general, because it is fairly saturated. But I think I heard a story the other day that people are traveling from, like, other countries in some cases to come to Cleveland for specialty care. So I'm sure we're saturated. You're saturated in some ways.
Yeah, we have had people though come from other countries for care in our NICU. We've had people who both have Americans who've been out of the country for delivery who have come back to us from other countries. We've had people come as natives of other countries. There are some specialists where I think it's more common in hematology and oncology, but again, pediatric cancers are pretty rare, and so people go where the specialists are. And so there have been people who've come from other countries for oncology care in the States.
You made a special note here about blood collections in the scalp.
So this is a good one.
What's that all about? Yeah.
This is a good one. So this is dealing with delivery trauma. And it's not uncommon to have some degree of trauma to the head when the head is passing through the vaginal canal and passing through the pelvis. And there are different kinds of blood collections in the scalp, and some of them, they can all come in various sizes. There are ways to tell them apart, but some of them are much more overall significant than others. Okay. So the most common one is going to be a caput secundum. So that's going to be at kind of the crown of your head, and it is kind of swelling and edema mixed with a little bit of blood. So you'll kind of get all of that in there, but it's that boggy feeling. I'm sure you've all seen it and felt it, but that boggy feeling sort of at the top of a baby's head once they've come out. And it'll be right at the crown of the head. It'll cross suture lines, which is a big thing.
Big deal, yeah.
So that's just edema. It's edema mixed with some blood. It's not going to be dangerous. It's not going to collect a lot of blood. And ultimately, it will reabsorb with time and not be a big deal. The next most common one is going to be a cephalohematoma. So that one's going to be bleeding in the subperiosteal space. So because it's subperiosteal, it's going to be associated with one of your bones.
Okay.
So it's not going to cross suture lines by definition because it is associated specifically with that bone. So if you see a swelling, it's going to be to one side of the head or the other. It won't cross. You know what I mean by the suture lines?
Yeah.
Okay. So it won't cross those suture lines. And those also tend to be, they can be bigger or smaller. They can collect a fair amount of blood, not a ton. Over time, they also reabsorb. If they're big enough, they can take a while to reabsorb. They can be a reason babies will get significant hyperbilirubinemia, because hyperbilirubinemia comes from breakdown of excess blood. It's a byproduct of hemoglobin, bilirubin is. Yeah. And so as that reabsorbs, you can sometimes get hyperbilirubinemia.
All right.
Those can also calcify, and so not commonly, but if you have a big one that doesn't seem to be reabsorbing, sometimes later on neurosurgery will go in and drain that.
They get decompressed, yeah.
Mm-hmm. And then there's the one to be really worried about, and that's the subgaleal hematoma. Okay. It's a shearing of the subcutaneous layer in your scalp. Okay. And there are arteries and veins that run through there, so you can actually get arterial bleeding into that subcutaneous fat layer. And because it's subcutaneous fat, so it's easy to move around, it's easy to shear, and so you can shear the entire subcutaneous fat layer surrounding your scalp. And because there's arteries in there, you can actually get a rapid arterial bleed. And so a baby can bleed their entire blood volume into their subgaleal space.
Really?
Yeah. So the capits aren't anything to worry about in the acute period. Yep. The cephalohematomas aren't anything to worry about in the acute period. The subgaleal hematoma is something that you'll transport a baby for. Okay. So things to look for. What it looks like to me and how I describe it to trainees is it'll look like and feel like water in a Ziploc bag. So it'll be very loose and fluctuant. It'll move dependently. So if you turn the baby's head, it'll move with it. And they can expand rapidly. So the kind of hallmark sign is it'll push the ears forward.
Makes sense, yeah. All right.
But that's one that you want to transport quickly, because they can crash on you really quickly.
I would want to go to a specialist for that, probably not just any ED.
I was going to say,
can you do anything for that? Yeah.
You give blood.
Okay.
There's nothing you can do to stop the bleed. Sometimes neurosurgery will wrap the head. There's actually no data that works. The theory behind it is just tamponade.
Sure.
Sometimes I'll wrap it and try to tamponade it. But the best thing you can do in the ED is give volume and give blood. Okay. Give volume while you're waiting for blood. But these are, get access quickly. If you can't get peripheral access, get umbilical access. And while you're waiting for your trauma pack, give saline. And once your trauma pack comes, push.
Most ERs, mine does for sure, we have uncrossed blood in our ER that we can have trauma blood we have access to. Mm-hmm. And most do.
Yeah.
Most trauma centers will have that.
Mm-hmm.
I think we hit all the blood collections in the scalp thing. I hope. Now we should have talked about this at the same time, but because it would have all flowed very nicely. But febrile seizures, and that kind of ties in with all the badness of fever to begin with.
The badness of fever and kind of the differences in seizures in neonates. Right. And so a neonate cannot have a simple febrile seizure. Right. So if you have a baby who is febrile and seizing, it is not a simple febrile seizure. So you can have simple febrile seizures between 6 months and 6 years of age generally, and they are kind of just what they sound like. So they are seizures that are associated with, I believe it's the cytokine release that comes with the production of fever. And it's not so much the degree of fever, but the rapid onset of the fever that's associated with febrile seizures. Mm-hmm. In neonates, if you have a febrile neonate having a seizure, your most likely case is that you have meningitis. But if you take the fever out of it, babies can have seizures for a variety of reasons. They can certainly have seizures from meningitis or encephalitis. They can have seizures from structural abnormalities, and there are a lot of structural abnormalities that can cause babies to have seizures. And they can have seizures from metabolic derangements. And so that one's an interesting one. A baby will often have to go home before they come back with issues related to metabolism. And the reason for that is during pregnancy, the placenta is, if mom is metabolically normal, mom is filtering out all the toxic metabolites that are making it to the baby. So it's not until a baby starts eating and then has to
process it,
has to have its own organs of metabolism that you start to see metabolic derangements in babies. And so in otherwise uncomplicated pregnancies with uncomplicated deliveries and babies who go home and, after even before 48 hours sometimes. Since COVID, there's actually been pushes for babies going home at 24 hours. you can have metabolic conditions that don't show up until people go home. Now, we try and as much as we can tease these out with newborn screens, and every state in the country has a newborn screening program. They're all a little bit different. But a lot of and you'll hear them referred to at some places as PKUs.
Okay.
So PKU, or phenylketonuria, is a metabolic disorder in which you can't break down phenylalanine properly. And the buildup of the metabolites of breakdown is what causes the symptoms of phenylketonuria.
Okay.
But you'll hear places refer to the newborn screen as the PKU, and that's because that was the first disease to be screened for in newborn screening. But now, depending on where you go, there's a whole host of metabolic diseases that's screened for in newborn screening. That the goal with newborn screening is to catch these things before they become symptomatic.
And that's why you have warnings on some of your gum that say contains PKU or certain foods. All because of that.
Yeah, aspartame contains phenylalanine, and so any of your diet soda products, any of your gum. Yeah, so safe sleep is so important. And I'm sure everyone, at least here, has heard of the Back to Sleep campaign. So that was the first major public health step in the safe sleep campaign. And what that came from was the realization that a significant proportion of what we used to think of as sudden infant death syndrome or unexplained near death comes from unsafe sleep. It comes from suffocation. So when babies are newborns, they don't have the strength and ability to turn their heads. And so if they somehow wind up in a position where their face is down in their bedding, or their face is covered by a blanket, or their face is, covered by a stuffed animal, or even pacifiers with things attached to them can get wrapped around the neck.
Sure.
These are all situations in which a baby may know that they can't breathe, but they can't do anything about it. And so until babies have the musculature to move their heads when they can't breathe, we need to put them in situations where they can't get into situations where they can smother themselves. And so that is the first step to that was the Back to Sleep campaign, where we have all babies sleep on their back. This has expanded some over time, and so we talk about the tenets of safe sleep. So it is alone. So the ABCs of safe sleep are going to be alone, on your back, in a crib. Other things are preventing smoke exposure in the environment. So we talked about co-sleeping. Co-sleeping or co-bedding is going to be where a baby is sleeping in a bed or in a bed with other people.
Right.
So it's not just the bedding in that situation, it is also the other people. Yeah, the other people. And it can happen, and I'm sure many of the people who are going to see this know, newborns are exhausting, and being a new parent is exhausting. And sometimes even people with the best of intentions fall asleep with their baby in their bed while they're feeding their baby or holding their baby.
Or holding it, which I've done, and you wake up and you're like, oh crap, that's so scary.
Yeah, exactly. I mean, and babies need to eat at night, and sometimes the easiest way to do it is in bed.
In bed, yep.
And so there have been cases of people who have fallen asleep with their babies in their beds, and babies have been smothered either by adults rolling over onto them, or babies who've been on chests who have gotten their face down in the chest. People sleeping on couches with babies, and the baby getting kind of wedged in a corner of the couch. So when you feel yourself starting to get sleepy, or when people feel themselves starting to get sleepy, the best thing they can do is put the baby down.
Put the kid down, yeah.
And I mean, it can be really hard, right? There are some babies who will only sleep when they're being held, but a crying baby in a crib is safer than a sleeping baby on the chest of a sleeping parent.
And there's those parents that are always like, oh, it never happened to us. And it's like, it can, and it will if you don't. Yeah.
Yeah, it doesn't
It's so
discriminate.
scary. It really is.
So RSV is a respiratory virus. It's respiratory syncytial virus. It is ubiquitous during some periods or some seasons of the year in certain places. Different places will have slightly different seasons depending on their climate.
Okay.
So the season in warmer climates tends to be almost year-round. So think about in South Florida, there's pretty much no season. It's always RSV season in South Florida.
Yeah.
In the more representative parts of the country, or the places that have more common seasons of the year, it tends to be in the fall and the winter. So the onset of RSV season tends to be in kind of September, October, and it tends to last through February, March, April, around there. So it's super common. It's one of your daycare viruses.
Yeah.
It's something that we all probably get every year. It is something that in older kids and adults causes colds if you're not immunosuppressed. So you'll be sneezy and coughy and just kind of generally feeling unwell.
Right.
But for most people, it's not dangerous. It's just inconvenient. For babies and people who are immunosuppressed, it can be really dangerous. And so the best thing we can do for babies and people who are having babies is to immunize. Now, it has just, and actually it's come out for older adults now too. So for older adults, we can vaccinate now. And for pregnant women, we can vaccinate for RSV.
Nice.
The goal with RSV vaccination for pregnant women is kind of twofold. So the more obvious one is to try and prevent RSV. Mm-hmm. But the more subtle one, and the one that we're actually going for, is the passive immunity that you'll get when a pregnant woman creates their antibodies to your RSV vaccine. And you get transplacental transfer of the antibodies to the fetus. Yep. And you're not directly immunizing your fetus, but you're providing passive immunity. So it's not going to be a situation in which the baby... that is not a vaccine for the baby. It's passive immunity. So it's there while it's there, and then it goes away. We have found that the vaccines are not effective in kids and newborns. And so what we have for newborns is another form of passive immunity. So we don't have a vaccination, but we do have immunization. Up until recently, we used something called palivizumab, or you've probably heard of it as Synagis. It's a monoclonal antibody against RSV. It required monthly dosing throughout the season, so babies who were receiving it were receiving it every month until they were done with the season. And it would protect them throughout that month. And once its half-life was up, or the baby had metabolized it, they're not immunized or protected anymore.
Another dosing.
Because of the dosing schedule and also the cost of it, the AAP had to put out recommendations as to who should get it, and really for who was at highest risk of rehospitalization and death due to RSV. And so it was something that we saw a lot in our neonatal population, because the population that is most at risk is going to be your preemies and your babies who have anomalies of the lung or anomalies of the airway, cardiac anomalies, things of that nature. So we saw it a lot, but the general population didn't see it a lot.
Sure.
So last RSV season, a new monoclonal antibody came out. This one's called nirsevimab, or its brand name is Beyfortus. So this one was super exciting. Yeah, you may not have heard of it.
I know. I don't think I've ever heard of it.
This past season was its first season. So this is also a monoclonal antibody, so it is also providing passive immunity. Mm-hmm. But the two things that make it different from Synagis is that it has a much longer half-life. So it's a single dose immunization that you get, and then it's meant to last you through RSV season.
That's awesome.
And it is considerably less expensive. So
bonus.
Yeah. So it's single dose injection, so you don't have the things like, loss to follow-up, or having to track patients down, or babies having to go through the pain of monthly injections.
Right.
And you don't have the cost of the monthly injection that we had before. So Synagis was about $2,000 a dose, whereas the cost to the provider, so the cost from the drug company to the person giving the drug of Beyfortus, is about $500. So considerably less expensive.
Considerably, yeah.
So because of that, it's been able to reach a much broader population. So when Beyfortus came out, the package insert labeled it for anybody less than 8 months of age at the onset of RSV season. So all babies.
Wow, very
all babies
broad,
who are less than 8 months at the onset of RSV season. Mm-hmm. And if you get it during RSV season, then you should get it when you're born. So the intention then is to make it kind of part of the newborn immunization schedule, and I think ultimately it may make its way onto the newborn immunization schedule, but to be given at the same time that you're getting that newborn dose of hepatitis B, giving that dose of newborn Beyfortus, if not in the hospital, and then giving it at your first pediatrician appointment within the first week of life, and having all babies then protected throughout RSV season, which is really exciting because while the NICU baby is the one that is most likely to get rehospitalized, if you look at the statistics, there are so many more term babies than there are preterm babies. And so while the greatest proportion of preterm babies is going to be rehospitalized with RSV, the greatest number of babies overall, so the greatest absolute number of babies overall getting rehospitalized is going to be term infants because there are just so many more of them.
Right.
And so it really has potential to make a huge public health change.
I mean, and RSV, as you said, can affect your NICU patients or a normally developed, normally birthed child that just is really susceptible to RSV or gets it at the wrong time, and then they end up in the hospital. They end up intubated, or they end up on high flow oxygen, or whatever they need to.
Yeah, and just by absolute numbers, most of them are going to be that baby.
So keeping those kids out of the hospital is a huge win.
Yeah. It has the potential to not just decrease cost to patient, but decrease overall healthcare costs.
Anything else on your mind? We had a bunch of stuff on this list.
The one thing I do want to bring up, we talked about before the episode, is when you deal with a lot of preemie babies. So at what age or how do we talk about, like, oh, my kid was born at 32 weeks gestation? At what point do we say, or have they kind of caught up to normal development? Do you still say, oh, well, we're born at 32 weeks and now we're 2 months old? Are they 40 weeks? Do we call them 2 months old? How do you treat that child? Do you treat them by gestational age, or you treat them by their birth age?
Actually,
Different
somewhere between.
Different for different things. So just because we were just talking about it with regard to vaccines and immunizations, that's always done by absolute age. So a 32-weeker born, or a 32-weeker will get immunizations for the first time at 2 months. A 40-weeker will get immunizations for the first time at 2 months. With regard to neurodevelopment, we correct for gestational age. So we'll talk about the absolute age, and we'll talk about corrected gestational age or postmenstrual age. So you'll hear us talk a lot about a 32-weeker, 2 months old, corrected to 40 weeks. And we will do that until a baby turns 2 years old.
Okay.
After 2 years, we stop correcting developmental milestones for gestational age, and that also applies to the growth chart. So when we're looking at growth, we also correct for gestational age up until 2 years of age.
Okay.
Now, there are some things from your newborn state that are going to follow you throughout life, or will follow you throughout childhood. So babies who are born prematurely, oftentimes the most common thing is going to be lung disease. And while the majority of them don't need support when they go home, they'll still have kind of some of the phenotype of premature lung disease. This tends to manifest in terms of wheezing. It's not quite the same phenotype as asthma, but it does tend to manifest in terms of childhood wheezing. And so while we're not necessarily correcting for age for that, it is important information. So if a baby comes into the emergency room with, wheezing or respiratory distress, and you're told, hey, this is an 8-month-old who was a former 24-weeker, you may think a little bit harder about their respiratory status than you would about an 8-month-old who has some wheezing.
Sure. Yeah. So that's one. I guess I kind of intrinsically do it. I would, if I was calling you for help, right? I'd say I've got a prior 32-weeker at 8 weeks, right?
Yeah.
So you already have all that information. I guess in my brain is like, am I going to present that at like?
Yeah, it feels kind of
20 at 23 weeks old or 23 months old, right?
It feels kind of silly, right? When you're calling a pediatrician or you're talking on the phone with the PICU and you're like, hey, I have this 16-year-old who was a previous 32-weeker.
I tend to leave that out, but at the same point, if they lead in with, I was a preemie and I've had lung issues, and now I'm here because I have shortness of breath or some lung issues, it's
relevant information.
It's relevant to me. I'm going to pass that along.
Yeah.
Say, hey, PICU, they're 16 now, but they had multiple NICU stays for lung development issues.
Yeah.
They've had long or have required long bouts of ICU stays, maybe some intubations, or maybe long doses of steroids or whatever the treatments were, because it's pertinent to what's going on. And hopefully those patients are going to volunteer that information, but sometimes they don't.
Are you suggesting the story's important?
I am saying the story is very important.
The history is always important. But I mean, I'm sure you remember, and we were all trained, right? Whenever you're seeing a patient for the first time, you ask them about birth history.
Yes.
And so I'm sure you have been presented by a resident that this is a 16-year-old who has burning when they pee and they were a 32-weeker. And less relevant.
All right. Anything else?
I think that's it.
Doctor, anything else on your mind?
I don't think so.
We had a bunch of stuff.
I know.
Here.
We went all over the depths of my mind.
all of ours at some point. So, all right. Well,
this was fun.
Yeah. No. Again, thanks for coming back, and we'll see you on whenever this becomes the live show. So.
Yeah. And for those out you in podcast land or YouTube land, subscribe us on YouTube, and we'll have at least 1 hour of free Ohio CE available for this episode in peds, which I know that a lot of the Ohio providers will need their pediatric CE.
Absolutely.
So go ahead and get that. And
prehospitalparadigm.com.